Okay, hi guys.
Hello.
Do you want us to start? Like, خلاص? يلا. Wait, I removed the chat box.
No, it's fine.
Okay, yeah, let's go.
Okay.
I don't think we need to like make a introduction. خلاص, you guys know. We're gonna like give you questions, and inshallah we're gonna explain like the reason, like why the answer is so. Anyways, let's start.
That's what. Okay. So we'll start with something like really simple about lung volumes. So, do you guys want to read it or like?
Yeah. Does anyone want to like volunteer and read it
or
out
do you just
loud?
want me to
Or do you want? Yeah. Guys, this is Ibrahim's laptop, so we're struggling. Wait.
Go down. Oh no.
So no one wants
Okay,
to...
someone answered already.
Oh,
But okay, I'll just
we'll just read it. Yeah.
Okay. So in the spirometry trace below, shown below, which table correctly identifies the inspiratory reserve volume and which table identifies the expiratory reserve volume?
So what do you think the answer is?
It's kind of easy, but it's like the like the first like the part of pulmonary physiology. Okay, so we have C, we have D. What do you guys like?
And explain why you chose a certain like choice.
Okay, wait. So far, how many people do we have? So far, we got 3 answers. Yeah, it's like C, D, and then C. If you guys want to answer in the chat, and if it's wrong, it's fine. We'll explain.
Yeah, we're gonna explain why. Okay, so till now, most of you guys are saying C.
Yeah.
Let's check.
Okay. So the answer is C. Because there's a graph that explains after this there's a graph that explains like all the volumes and everything, but essentially like the one you see here is the tidal volume. It's the one you normally breathe in and out, and that's D, right? So once if you inspire air, like the volume increases. So if you force yourself to take in more air in, it's going to go up to a maximum, which is like to this point. And this whole thing, like from this point to this point, the extra air that you take it in is the inspiratory reserve volume. Now I said, okay, so so that's the volume. And if you want to say capacity, like if you want to so basically capacities are like sum of the volumes. And I'll just try to explain that just a second. Okay, so inspiratory capacity is the sum of the tidal volume with the inspiratory reserve volume. So A is the answer for inspiratory reserve
But if
volume.
you want the inspiratory capacity, it's gonna probably be something that is like A plus D, you know, because it's usually the tidal volume plus the inspiratory reserve volume. Right?
Now, someone answered D, which says the inspiratory reserve volume is B. Now, this part here, it's all exhalation because you're losing all the air in your lungs, right? So the extra, wait just a second. Oh, so the expiratory part has 2 parts. There's one that's called residual volume, which is F, and the expiratory reserve volume, which is E. Now, there are 2 different parts because when you exhale, you can't push out all the air in your lungs, right? There will be some, always there will be some air left in the lungs, which is F. That's why there's residual volume. E is the same, thing when you force out your breath. That's the maximum you can let out. And then
as we said, F is the what is it called? The residual volume. It will never leave. It's the thing that keeps your lungs inflated inside your body. So if you wanna exhale, everything you exhale is gonna be only E. It's not gonna be EF because E and F together are the functional residual capacity, or basically the RV plus the expiratory reserve volume. And we said we want the expiratory reserve volume. That's why it's gonna be E. Okay. So do you guys have any questions? Is anything about that confusing?
Okay, that's clear.
Okay. I'm gonna move on to the next one. Okay, so which of the following lung volumes or capacities cannot be directly measured using a spirometry?
Okay.
Okay, great.
That's good.
So most of you guys are like answering the
D.
correct answer, which is
Oh.
wait. Okay. So I guess you guys all know why it's D. Does anyone want us to explain why? Or like it's fine.
In case like
Because total lung capacity, it involves residual volume, which can't be measured with a spirometry.
Exactly. So let's move on.
Yeah, we can move on.
Okay.
Okay, there's one more.
So a 35-year-old man has a vital capacity of 5 liters, a tidal volume of 0.5 liters, an expiratory capacity of 3.5 liters, and a functional residual capacity of 2.5 liters. What is his expiratory reserve volume? Yep.
Whenever you have questions like these, you can like draw them out to kind of make sense of the volumes.
Or like highlight the most important like values that you want to use. Okay. We got an F for now. I can see clearly, guys, your mental math is very slow.
Okay, so far someone said F. That's it.
G, E.
Math. It's fine. It's like yeah, you learn with this question.
We got to never mind too. Two guys.
D.
G.
G.
Okay. So the right answer is G. Okay, let me explain. So basically, we want the expiratory reserve volume. All right. And we said that like let's look at what they gave us. They gave us the vital capacity, the tidal volume, the expiratory capacity, and the functional residual capacity, which is 2.5. All right. Now, to get the expiratory resolve volume, okay, we have to look like which of those values in here, like if we add expiratory reserve volume to another value, it will give us like a third value, which we have in here, because you have here like 1, 2, 3, 4. You have 4 values, all right? So let's look here. Wait, sorry. Let's look here. We can see basically that the vital capacity in here, all right, it is made up of the inspiratory reserve volume, the tidal volume, and the expiratory reserve volume. And it's made up of the inspiratory capacity and the expiratory reserve volume, because if we add this to the IC, it will give us the vital capacity. So if we go back, all right, they gave us the vital capacity, which is 5, and they gave us the inspiratory capacity, which is 3.5. So basically they gave us like all of this, which is the 5, and they gave us the 3.5, which is the inspiratory capacity. So we like end up with the inspiratory reserve volume left. So we can do 5, which is the vital capacity, minus 3.5, which is the inspiratory capacity, and then we're gonna get 1.5, which will literally equal expiratory reserve volume. Is it clear?
Okay.
Do you guys have any questions? Okay. I feel like, guys, if you memorize this, it will make your life easier. Like مثلا, if you memorize how it looks, and then once you get to the exam, you directly draw it out on the paper that they give you, it's gonna help you with any calculation that you need to do.
Yeah. Also, I forgot to mention
what about tidal volume? Tidal volume Okay, listen, like inspiratory capacity, as you can see, it includes the tidal volume. So
it's like the normal breathing with the extra, like you can breathe. That's
exactly
inspiratory capacity.
But I have a question. What do you mean by what about tidal volume? Like,
We
do you
don't,
mean what is the value or what?
Yeah, you don't need to use tidal volume in this question because like inspiratory capacity is like a part of it is tidal volume. I think that's
like you can look at the values, all right? Like when I look at this question, I'll see like, okay, I have this value, this value, this value, and then I'll look.
okay.
Okay. Then I'll look here and I'll see which value will help me to get it. Like if I look if I use the 2.5 or 1.5, I'd be wasting like my time because they're not gonna help me actually find the like ARV, you get me? But I feel like if you guys memorize this, it's gonna be of so much help.
Yeah.
Do you guys have any more questions? And if you don't understand anything, Adi, tell us to repeat. We don't mind.
Yeah.
I'll take the silence as a yes.
Okay. Yeah. Okay. So next question. The next diagram shows two lung units, S and T, with their blood supplies. Lung unit S has an ideal relationship between blood flow and ventilation, but lung unit T has a compromised blood flow. What is the relationship between alveolar dead space, physiologic dead space, and anatomic dead space for these lung units?
So what do you think, guys?
Okay, someone said B. No, D.
D. D.
Okay.
Okay, so does anyone want to explain why D?
Yeah, maybe that's good.
Because in D, because in S we're having the physiological is the same as anatomic, which means that the bronchi that are not, there's no ventilation happening or gas exchange is the same, but in the lung unit T there is a constriction, so there is a perfusion, and some bronchi are not receiving perfusion, so there is no gas exchange, so the physiological dead space is going to increase since some bronchus are not receiving blood. Does it make sense?
Yeah. Okay, I'll explain it. What he said was completely right. I'll just explain it in case like with this diagram, because it helps. Like I feel like it helps you like visualize what he said. So anatomic dead, like what we mean by anatomical dead space is the air that's conducting, that's in the conducting airways. So like for example trachea, there's no gas exchange that happens there, right? So that's like anatomical dead space because the air is flowing, but there's just no there's no exchange that happens because it's not an alveoli yet. But then when you go to alveolar space, some of the alveoli don't get blood supply. Like something happens with the blood supply or it gets compromised for some reason, then you would have alveolar dead space because now the problem is with the blood supply. There's not enough blood, so like exchange is less. So we call this alveolar dead space. Physiological dead space is the combination of anatomical and alveolar dead space. So you would normally add these up. So for example, in oh, where did you? Okay, sorry. Oops, I'm sorry. Okay, for example, in S, there's no blood supply is fine, right? So you would and there's no alveolar dead space. So the physiological dead space would be equal to the anatomical because you're not adding it to anything. Now for T, since there's like compromised blood flow, there is alveolar dead space. So that's why the physiological is more than just the anatomical. Since you're adding them, this would be more than just the anatomical dead space because now there's blood supply that's affecting you. Is that clear to everyone?
Okay.
Then
sorry, okay. Can you repeat it briefly?
I can.
Sure.
I showed the next answer first. It's fine. Okay, anyways. So there's something called physiological dead space in our lungs, and it's normal to have that. Like if it's not extreme, we have anatomical dead space and alveolar dead space. Now, the air, for example, the air in the trachea, the air in the bronchioles, for example, they don't take part in gas exchange, right? So they're technically, like, they're termed as dead space, but they're anatomical dead space, because the reason there's no gas exchange happening is because of their anatomy. Like, it's not an alveoli yet, so it's not thin enough to, like, for the gases to diffuse. Now, when you come to the alveolar, like the sacs, gas exchange normally does take place, but if there's something wrong now with the blood supply, for example, like here, there's like stenosis or something, it's harder for the gases to pass through because there's less blood coming through it, right? So that's why we call this alveolar dead space. Okay.
And physiological is just both of them together.
Yeah, that's what I mean. So, like, if you have no alveolar dead space, which means you don't have any problem with the blood supply, for example, in unit S, there's nothing wrong. It's just there's air here, but there's no exchange. I mean, there is exchange, sorry. It's not compromised. The physiological would be the same as anatomical. Like, this one would be equal to this because there is no alveolar dead space. Did you get me? Okay.
All right, let's move.
If you have any questions, just ask. Like, it's fine. You can ask anything. Yeah.
Okay.
Sorry.
Okay. So a 59-year-old man presents with a dry cough and progressively worsening dyspnea over 10 weeks. A lung function test is ordered and all lung volumes are reduced, but the FEV-FVC ratio is unchanged or slightly higher than normal. Based on the likely diagnosis, which curve or line on the figure most likely represents the expected changes reflecting the lung compliance of this patient? So explain why, because you guys saw the answer. You should explain why.
It's restrictive lung disease.
Exactly.
Everything increases. And the
Okay, so
FEV-FVC ratio is either like 80% or a little bit higher.
okay, perfect. He probably has fibrosis which decreases exactly. So this is like a case of pulmonary fibrosis, and as Shahad just explained, it is a restrictive pulmonary disease. Therefore, when we see like this FEV equals FVC ratio is unchanged or slightly higher, you directly know that it's restrictive, it's not obstructive. So in restrictive diseases, usually the compliance is decreased. So we will definitely look at anything that is decreased. So it's probably going to be E, and it's not going to be A or B because it's increased. And D, you can see that it's actually increasing, even though it's like below it, but it is, you can see like over time it's increasing. So we have to check which curve is like kind of mimicking the normal, but at a lower level, which is definitely E, because as you can see here, it's like not a curve, it's like a straight line. So we will, whatever is a straight line, we're just going to remove. Like F and B, there's no way they're the right answer. So we're just going to go with E. Do you guys have any question about this? Oh, clear. Perfect. And this is literally what we said earlier. In obstructive pulmonary disease, FVC and FEV will decrease. And if you look in here, حتى restrictive pulmonary disease, both values will decrease. But why? But like you might think, why obstructive pulmonary disease, the ratio would be decreased, but in restrictive it won't? Because basically the decrease of FVC and FEV in restrictive pulmonary disease is proportional. So basically they're going to decrease at a proportional rate that even if we divide them, it's going to still equal 80%, or it might slightly be higher. Well, in obstructive pulmonary disease, the change will be like severe, you know, like they're both decreased, but one will decrease further than the other. That's why we're going to have a decreased ratio. And one more thing, I think in the slides, Dr. Shams had like an amazing like graph. You can guys refer back to that.
It's coming up. The graph,
No, it's not this.
Oh, no.
I didn't include it. Yeah.
This one?
No, there was this one where it had like
mind,
curves, and then they showed us how the restrictive is here and the obstructive is here.
Oh yeah.
Yeah, so this slide is nice to, it summarizes almost everything.
Yeah.
Okay, so shall we move on?
Just know what forced vital capacity and FEV1 means, right? Like the amount of air you expire in the first second or something.
Yeah, just understand what they are, because they might ask you such silly questions.
But
like you never know. and just understand the overall idea. If you understand how are they calculated and like how do they achieve those like results, then you're just gonna know how to answer any question. All right?
Okay. I hope that's clear.
I hope we did not confuse you.
Okay.
Because I'll take the silence as a yes because no one's
Okay.
answering.
Someone answered. Okay. A 35-year-old man came to the clinic presenting with shortness of breath that got worse with time. He can only walk about 20 yards without having to stop and get his breath back. And it's especially hard for him to breathe out air, and he's noted to be using his accessory muscles. Wheezing is noted on expiration, and he has a 30-year history of smoking 2 packs of cigarette per day. Now, based on the most likely diagnosis, which combination of changes is most likely seen in this patient? Someone said 2, someone said 1.
Okay, before answering,
1,
guys,
2.
what do you think he has?
Yeah.
Like, what's the
Because
diagnosis?
your answer would depend
Okay.
on. Okay.
Someone said
Wait.
it's emphysema, COPD, emphysema.
Yeah.
2.
Okay, yeah.
Okay.
So
you guys kind of got it. It is emphysema. So
COPD, emphysema is a part of COPD, chronic obstructive.
Yeah.
And yeah, since everyone is saying 2, that's the answer. Okay. So we got this question in our TBL in first year, and I remember, I still remember it. But so like your answer all depends on how you diagnose like this patient, right? So for example, like there are hints in the question itself. So wheezing is noted on expiration, especially hard for him to breathe out air, not breathe in, and he's using his accessory muscles. Now emphysema is like it's destruction, like it's easy to breathe in because like there's destruction of the walls of the alveoli, and so there's no problem in breathing in, and all the lung volumes will increase, but there's a problem in breathing out or exhaling. That's
the main
what you should
problem
know.
is in exhaling, because if it was restrictive disease, would the answer be 4?
Wait, let me see. Okay, so the volumes, yes, not the ratio. The volumes in restrictive would decrease because you can't breathe in as much. Restrictive is like it restricts your lung from getting like air.
Yeah, you can't take in
yeah,
air.
everything. Yes, exactly.
Yeah.
Everything except the ratio.
So basically, guys, in emphysema,
yeah,
the main
you're right.
idea is in emphysema, when you take in, like, it's not only the problem is with breathing out. Basically, you breathe in air, and then the air gets kind of stuck in you, because basically the main problem is in the bronchioles. So as you breathe out, the bronchioles will collapse, and then the alveoli will like be inflated. So this will increase the lung capacity or the volumes inside the lung. All right, that's why all the total lung capacity would increase.
Yeah. And like I guess all
the only thing that will like decrease is the amount of air you're excrete, like you're, let's say, like expiring. And if we look back here,
will it
the only thing
increase?
that will be affected is the ERV, because technically we're increasing everything, but when we want to exhale or expire, we can't like fully expire all the all the air that we took in. Therefore, the ERV is the only thing that is gonna decrease. Will it increase the joule volume because you can't do gas exchange with the gas you inhale?
Yeah, so there's like more left in your lungs. That's why one of the options, wait, let me go. So like one of the values in the table is, sorry for the abbreviations, but RV is residual volume, and it is increased. Yeah. And yeah, that's the reason. Physiological dead space would increase.
Guys, don't think of such details, because honestly, I don't know. Like, we really don't know. But the thing is, no, even
I
like
guess
we took it in third year, and we never talked about physiological dead space in any pathological like situation. So the physiological dead space is just something to know for now, and then you'll never use it in your whole life.
But I guess if they won't ask you, but
yeah,
I guess
won't
they would
ask you.
increase because like
Physiological dead space. Yeah, probably, because you're not gonna have
because you're not having
gas
that
exchange
much,
and stuff. Yeah.
But again, don't think that much. Yeah. Don't
overthink it. Yeah.
They're two different things. I have a question. Did you guys get this question anywhere, or did you see it anywhere? I just want to ask. Okay, fine.
Like, did you solve it before?
Because I'm scared he got this same question in your TVL, and then, I don't know. I was just scared putting it. Oh,
Yes.
okay.
Also, whatever.
It's
Who
fine.
cares?
Maybe you. Okay, it's fine.
Sanity, it's
'Cause
clear, right?
Yeah, it's clear. As long as it's clear. Okay. Now, there was so this is a follow-up question regarding compliances. So if your diagnosis is emphysema, and based on your previous answer, what would be the compliance of the lung, chest wall, and respiratory system?
We got it too.
We got another 2. Okay. I guess it's
So I guess it's two.
yeah.
I'm saying two.
But yeah,
Yeah,
it
it
is
is
2.
two.
Because like I said, all the volumes so now you have to think about obstructive or like restrictive diseases, and since it's emphysema, it's obstructive disease. Now all the volumes in the lung increase, and compliance, which is volume over pressure, compliance of the lung would increase. This is something like you can memorize as well, because as we know, compliance increases in obstructive and then it decreases in restrictive for the respiratory system. Now, for emphysema specifically, compliance of the lung increases, but the chest wall remains the same. But the respiratory system, which is a combination of these two, or like a balance between these two, will increase, because now you have the lung kind of like trying to, like, the compliance is increased. That's why. But chest wall, again, it's not affected, because emphysema mainly it's again affecting the lung or the alveoli in the lung.
It's
Is
gonna
that
affect the muscles
Yeah.
of the chest wall. So do you guys have any question about this?
I hope that's clear, because only 3 answered, so I was
Did you say that for restrictive, the compliance of RS would decrease?
yeah, it would decrease. There's there's more questions on it. Okay. I hope that's clear. Okay, so this is a table that was given in your lecture, and it helps like so much, because in case you get any questions like differentiating between the two of them, obstructive and restrictive. Now, obstructive, again, all the volumes will increase, but the ratio of residual volume to total lung capacity would also increase. But this one, restrictive, the volumes would decrease, like the individual volumes, but when you put it in a ratio, they would stay normal, because again, they're proportionally like decreased.
Yeah.
Okay. That's the difference. Like if you see this ratio, or the FEV1, FVC, that's your hint, like which one, if they didn't give you the volumes yet.
Okay.
That's it.
So the next question.
Mm.
Which of the following is illustrated in the graph showing volume versus pressure in the lung chest wall system?
Okay. D.
We need someone to explain why D.
Yeah. Okay, since everyone's saying D, like, can someone explain why? You can type it in if you don't mind. Wait, so the answer is
Yeah, the
It
answer is
D.
D. But it's like, why, guys? I want to know.
The black dot that shows the intersection is the FRC, and that's at 0.0.
Yeah.
And it's because
That's
the
it.
lung is like recoiling towards that, and then the chest wall is also recoiling
Yeah.
outwards, and then the lung is recoiling inwards towards it. So they both meet at that point, which is 0.
As long as you understand, like, the whole way to understand this is like the lung trying, like I don't know how to explain, but lung trying to collapse inwards and the chest wall trying to expand, and there's a balance between these two, and that balance would be this. The rest of the options are wrong because slope is not resistance, it's compliance. So whenever you have volume over pressure, that's compliance. And wait, because the doctor mentioned in the slides that 0 represents FRC in the graph of respiratory system. Yeah,
that's proof.
that's
Literally it.
yeah. And all of these options are wrong. So that's why. Yeah. Oh, and this is a graph that I was talking about. Since all these like questions were about compliance, just know that this graph represents that. And in emphysema, it would increase. In fibrosis or restrictive lung diseases, it would decrease. Okay, so the slope would change with that. That's all. I hope that's clear. Because resting volume is FRC, and that's when you add the resting volume of the lung and the chest wall, and they're opposite to each other, so they counteract and join together because they are connected and work together. Yeah, that's
perfect.
Yeah, just because it's like to us, I just wanted to read out for anyone who's like, yeah. Okay.
Next, sorry.
It's
was
fine.
a lot of words. Okay, guys. So basically, we have two alveoli of different sizes, and they're both connected to the same airway, as you can see here. If the surface tension in both of those are same, the pressure produced by the surface tension will be higher in which alveolus, and in which direction will air flow between the two alveoli. So we got an A.
Okay.
Did you guys get this question before?
That was so fast.
Did you guys get it before? Because this was in our TBL too.
Yeah,
I saw it in a book. You guys send your explanations in the comment chat. I want to read them.
Yeah. I that's why we're reading about
We saw it in batch 13.
Oh
TBL.
no!
Yeah, it is our
in our
batch.
TBL. All this.
I think, yeah. You know, guys, we had this question and it was so confusing to us. It was in the mock exam. It was so confusing to us because I don't know, all the batch got it wrong. Like
yeah, for us, yeah, it was so bad for our TBL.
So okay, since you all guys know it, explain.
Because the smaller the radius, the higher the pressure, and so air is going to want to flow from high pressure to low pressure. So since 2 has lower pressure, it's going to go from 1 to 2, even though it's bigger.
What's the law that you base this off of? Like, why does it have higher pressure? What's the law called? I'm just asking whether just to like.
I forgot.
Okay, it's fine. Oh wait, yeah, that's
Laplace.
Right. Laplace. Laplace law. Yeah, that's right. By the way, I was just asking like just to make you think. It's fine. I wasn't meaning. Okay, we'll give you more time to think too for the next one.
Yeah.
Okay. I guess that's it. So the answer is A. You guys are right. That's
and the explanation is spot on.
Yeah.
And as Momo just mentioned, this is explained by Laplace law and the surfactant like presence, since it's like you guys see in here, they mentioned that the surface tension is the same, and usually the surface tension is due to the surfactant, like the presence of the surfactant. And
so like since
the
next slide.
Sorry,
it's okay.
Yeah,
so like surface tension is the same in both. That's what they mentioned. And radius is smaller.
It's smaller in like in A, it's smaller in 1, and then it's bigger in 2. And then we said, as she mentioned, since the radius is smaller, the pressure is going to be probably higher, because you guys see in here, like the pressure and the radius are inversely proportional. So if we increase the radius, the pressure, never mind.
Yeah. So
they're
decrease inversely, so like it's over R.
If we decrease the R, then we're gonna increase the pressure. Sorry, so when we decrease the R, we're gonna increase the pressure. That's why the pressure in 1 will be higher than the pressure in 2, and because the pressure is higher in here, it will go from 1 to 2, right?
In the previous question, the labels are like,
is it clear?
I just asked like the law because there's a similar law in hemodynamics, like in the blood vessel, that's called Laplace law. But okay, all clear.
Okay, and move on. Okay, so a 78-year-old man who smoked 60 cigarettes per day for 55 years complains of shortness of breath. The patient is diagnosed with chronic pulmonary emphysema. Which of the following sets of changes is present in the man compared to a healthy non-smoker? I'm not gonna say the answer out.
Oh yeah,
Let's
wait,
give them
wait.
time. Okay, so most of the answers we're getting are correct.
Yeah.
It is E. And I think we already went through it. Like we said
Yeah.
that basically in emphysema, the compliance is going to increase. So compliance and elastic recoil, they're inversely proportional. If the compliance increases, the elastic recoil is going to decrease. So therefore, that's why the elastic recoil in here decreased. And I mentioned earlier that basically emphysema, we're going to have more air stuck in the lungs. That's why we're going to have the total lung capacity increase. Is it clear?
Okay. Someone answered D, but
I want to ask why. Like, why do you think
yeah.
D? Is it because of the total lung capacity? Because that's the only difference.
Yeah, I guess that's only. But total lung capacity again, it's not the it's all volumes increase with obstructive.
Yeah, only the ARV is going to
Yeah.
decrease. It's okay.
Yeah, it's fine.
I have a question.
Oh yeah,
Yeah, sure.
Go back.
So in the obstructive diseases, we have increased compliance and we have an increased volume. But isn't it like when we have increased volume, we have decreased compliance?
So compliance is volume over pressure, right? So let's say the volumes of all the the parameters increase, then compliance would increase.
They're directly proportional, like if we increase the volume, then what is it called? The compliance is going to increase. And we said that basically the total lung capacity is increasing because of the air that is getting stuck inside the lungs.
Yeah.
So it's going to increase the compliance.
Of the lung because it affects the alveolar walls.
Okay, thank you.
Okay. Because someone said because you have an
increasing compliance, you can have a higher volume because it can expand. Okay.
So a 27-year-old pregnant woman is rushed to the emergency department following a car accident and delivers a premature baby girl by cesarean section at 30 weeks of gestation. The baby is 3 pounds 4 ounces, and the newborn is tachypnic and dyspneic. Okay. Which of the following changes to alveolar surface tension and lung compliance are expected in the newborn compared to a healthy?
Okay. I love how fast you're answering, guys. It's either you have the questions or they're very easy.
That's why.
Or you studied really well.
Because at this time I wouldn't solve practice questions yet.
Me
so I'm like,
too.
oh, that's good.
So I'm proud of all of you.
Yeah. Okay. So
so most of you guys, said B, and then we got D. So let's see what is the right answer. B. Okay. So
wait, let me see if I put an explanation. Oh, okay, it's the same one.
Okay. So basically,
you want to explain it?
I don't mind. So basically, the main problem that this the baby is having, since he's a premature baby, then the surfactant is not yet fully developed. So because the surfactant is not there, then the surface tension of the alveoli will increase a lot, because you know how the surfactant is the thing that maintains the tension in the alveoli, and because we have increased surface tension, the lung compliance is going to decrease.
Yeah. Because when you have,
I'll go back to the thing we did.
Okay, they got it.
Yeah, here.
So when you have increased surface tension because of lack of surfactant, you would have increased pressure. Now, increased pressure is inversely proportional to compliance. Again, compliance is volume over pressure. Now, when pressure increases, the compliance would decrease. That's why. Did you guys get it? Okay. So wait, I just want to see what D was.
D was
was-
increased alveolar surface
Oh,
tension.
D was.
Oh, yeah,
sorry,
yeah.
Compliance. Yeah,
increased
so you get
compliance.
you get what it's the opposite.
I just
Yeah,
didn't
it's
read
okay,
it
it's
properly. It's fine.
It's fine.
Okay.
Okay. Now, a 26-year-old woman presents to the urgent care facility with rapid and shallow breathing for 1 hour. She describes having an anxiety attack and cannot catch her breath and complains of dizziness and tingling in her hands and feet. Her heart rate and blood pressure are slightly elevated and body temperature is normal. Which of the following changes is expected in this patient? Now we moved on to oxygen dissociation. What? Okay, I'll just wait a bit for everyone to answer. Okay, it's fine.
Okay, so we got
Okay,
B's and
B and
D's.
D.
Okay, but the right answer is A.
It's fine. But I just want.
Okay, so let's wait.
Okay,
We'll go to.
we
I
can-
think you can.
yeah, we
explain
can
it here, right?
explain it from here. So normally you would have the oxygen like dissociation curve. It just means like how strongly oxygen can be bound to like hemoglobin, right? Now this is the like the normal curve, and when you go to the left, like there are changes that happen that can shift the curve to the left or the right. Now this, when it goes to this side, it's left shift. When it goes to this side, that's right shift. And there are like different factors for it. So I'll explain with the question. So the question says like she had an anxiety attack and she had rapid and shallow breathing, but none of her symptoms affect O2. I know. But wait, okay, so this question, it makes you think like it leads to like I don't know how to say it, but it leads you to think about oxygen dissociation
Yeah,
first.
because basically,
Now, yeah.
the main important thing is the rapid and shallow
Yeah.
breathing.
So like imagine like a person is hyperventilating, and which means that she's breathing rapidly. That means that you're losing a lot of carbon dioxide from your blood, right? So arterial PCO2, which is E, would decrease because you're exhaling a lot of it out. So there's less carbon dioxide in the blood. Now that means that the pH of the blood will be high or low. If there's less carbon dioxide in your blood,
then the pH is
would
going
be
to
higher pH.
yeah, because it's gonna become
Because they're the
wait.
opposite. Yeah.
Higher, yeah, it's gonna become
Okay.
more alkaline because
Yeah.
we're getting rid of the carbon dioxide, which is acidic.
Yeah,
Yeah.
that's why. Now
So exact. Let's etch from
bicarb, yeah. So
since we are increasing the pH, so
we're increasing pH and
we're decreasing the H plus.
yeah. So it's left shift.
Yeah.
Do you get me? Because so wait. So this curve, this increases affinity, yes. So this makes the hemoglobin more likely to bind to oxygen, but so it can better supply your bodies. Now this graph, it only shows with left shift there's a decrease in everything, just so you can memorize it, and then right shift with increased everything. But when you go left shift, decreased H plus is the same thing as saying increased pH, and that happens with when you have low.
Can you go back?
Low. Yeah, sure.
Yeah, sure.
Low pH shift to left and vice. Yeah, that's basically it. Can you? Yeah, okay. Did you guys get it? Decrease in CO2 and H plus, and increase in pH will lead to left shift.
Yeah.
Okay, you got it now?
What about
Okay.
a decrease in arterial
Now
pH?
you're breathing rapidly and fast, right? Hyperventilating, which means you're getting a lot of oxygen in your blood. So there would be an increase, not
Yeah,
decrease.
it's not gonna be a decrease.
Yeah.
And then E is
opposite
wrong
for
too.
opposite for CO2. And then which one? Yeah. What were you saying? That's it.
Yeah, so basically it's gonna be an increase in
Mm.
arterial PO2 because she's like getting a lot of oxygen into her blood, like into her system. All right, is it
Is
clear?
that clear with everyone? Because that's the okay.
We can repeat if you guys want.
If you guys want.
Yes.
Yes, repeat or it's fine. I guess. Okay,
yes, it's clear. Perfect.
I'll just explain.
Wait.
I just want to explain this again. So this is the normal one, but if you have carbon like carboxyhemoglobin, the curve would shift, like the curve would look completely different like this because it's not oxygen anymore, like it's half, So that's the only difference. Just make sure you know the difference between these two. And I used to like memorize what caused left shift and what caused right shift. Yeah,
you can memorize one and then just know that the opposite
Yeah,
causes
true.
like مثلا you can memorize what causes a left shift and just know that whatever is opposite to that causes a right shift. That's how I did it. So
Just good. That's it from this.
that's okay. So let's go to the next question.
You can read it.
I can read
that's
it. Yeah, okay. So a person suffering from pulmonary embolism is observed to be cyanotic to have rapid shallow breathing. Which pulmonary receptors or reflexes cause the rapid shallow breathing in this patient? You got
Yeah,
a C.
We'll wait until but we got it. C.
B.
B.
E. Well, Stacey,
C
because it's
is-
the only one I know, and I know A, but it can't be. B.
Mhm.
B. Okay, so we have all over the place.
Yeah,
we
okay,
have
I
a
think,
B,
yeah.
a C, and E. Okay,
But
so the answer
is
is
B.
B.
So
But wait, those who chose B, why did you
you can
choose
explain
B?
it if you want. Because I want to know why they chose Barry. Okay,
Is
so
someone speaking?
whoever chose B, like tell us why you chose B.
I've never heard of that receptor in my life.
Oh,
It's on the slides in bold.
Okay. In the slides, it said pulmonary embolism activates these receptors. Okay, that's good. It was in the slide. So basically in your last lecture, in the eighth like the physiology lecture, there were all these receptors talking about like how they regulate your breathing. So basically the three main things we have are slowly adapting stretch receptors, rapidly adapting stretch receptors, and the third one, which is C fiber or J receptors. Now the important thing about it's important to try to differentiate between all three of them. So C fiber or J receptors, they're usually increased in they're activated by pulmonary embolism, and they result in rapid shallow breathing, which does happen in pulmonary embolism. But these receptors, I just wanted to know that these receptors are responsible. But however, the slowly adapting stretch receptors depends on how much the lung expands or how much distension happens in the lung. So rapidly adapting would depend on again lung distension and irritants, but it would cause cough reflex and so on. It's a much greater response. I just want to know since a lot of
The slow adapting effect change in water.
it
Can I
changes.
ask you guys a question?
Sure.
Okay.
Will this receptor lead to hypoventilation or hyperventilation?
Functions rapid shallow. It
hyper
causes hyperventilation.
because it's
Yeah, because of the rapid shallow breathing, then it's going to be hyperventilation.
So pulmonary embolism, I think you guys know it, but it just means like there's a blood clot, isn't it? It's
And
stuck in
embolism,
the,
it's something that basically stops the circulation to the lung.
Yeah, that's why
Alright.
you try to breathe in like as quickly as possible.
Because basically the perfusion is like, let's say we have low perfusion. So to compensate for that, you're gonna try as much as you can to. Isn't hyperventilation deep rapid?
Hyperventilation means rapid, like it just means you're breathing in quickly.
It doesn't mean the deep or the shallow. I don't think it's like, we only know that it's because of rapid. Like you hyperventilate when you're like breathing very rapidly, and usually when you breathe rapidly, you don't breathe deeply.
Yeah. Also, it's like a dog. Oh wait, Dr. Shams
dog
says it's like a dog panting. Yeah,
exactly.
That's true.
So it's shallow usually. So it's like very fast and very shallow.
Yeah. There was one there was one slide on your in your lectures where it said the true definition of hyperventilation or hypoventilation is by measuring PaCO2. I think it will come up, but I just wanted to say that if once you measure PaCO2, which is the arterial carbon dioxide, and it's low, that means you're hyperventilating. That means like whether it's rapid shallow or rapid deep, it means you're breathing in too quickly. Because you're losing all that carbon dioxide. Now, when it's high, it's the opposite, hypoventilation. That's it. I just want to, Do
you have any more questions?
Do you guys have any more questions from here? All clear. Okay. Like all of these, they don't relate to receptors or reflexes. Like receptors, I mean, in general. Baroreceptor is something else. It has to do with like blood pressure, which is not related to pulmonary.
The pulmonary embolism will not affect the blood pressure usually.
That's what I was thinking.
So that's why, and it's not gonna cause low blood pressure. It's gonna cause, I guess, high blood pressure.
Yeah, I guess it's
Yeah, because we have an obstruction. Yeah. Anyways,
and irritant receptors.
We said it's the
rapid.
The rapid, yeah.
Okay, that's okay.
So moving on to the second question. Guys, act like you we showed them the answer.
Anyways, I explained this. Oh no. Okay, what is the diagnosis of hypoxia using the parameters? Low PaCO2, high PaCO2.
The plus, guys, you know
whatever.
what?
Yeah, it's fine. No.
Whatever.
It's C. Everyone's saying C anyway.
Because we have like decreased PO2 because we know that there is no enough ventilation.
Yeah, that's the main. Okay, this was an easy question.
So it was, so it's fine. Whatever.
But just know, if you see mainly the determinant of like hypo or hyperventilation, you have to measure the blood gases.
Yeah.
Okay. You're not exhaling.
Exactly. So you're basically not taking in enough oxygen and you're not exhaling enough. So you have hypoventilation.
Okay. So you would have, in this case, you would have a high pH or a low pH. Just because we have
low pH.
Yeah,
low pH. Low pH. Yeah, that's correct. And low pH would mean right shift or left shift of dissociation.
It's going to be right shift. So because we have more carbon dioxide, which decreases the affinity for oxygen, and we're also producing a lot of hydrogen, which also changes the conformation of the globin, or changes the conformation of heme for the oxygen too. So we have two things that actually affect the affinity. So right shift.
Okay, perfect.
That's it.
Okay, let's go to the next question. Which of the following is the site of highest airway resistance?
And I think this was the question now. I don't.
Yeah, I remember something like that. A, C, D. Okay. E. We have ACE, like ACE inhibitors.
Wait, I don't think they know what it is.
I don't think,
That's funny.
You guys are lucky that you don't know. Okay.
Okay.
So basically, the correct answer is C. Okay, so basically, wait, I'll show the next one. As you can see in here, the like if you look in here, the resistance in the beginning, it starts to build up, like from the first generation up until like, let's say half of the, like, let's say like till 5, and then you can see how it decreases rapidly. And the most important thing in this is the sentence that the doctor says, literally here: the major site of resistance is in upper airways, 80%. Thus, measurement of resistance is a poor test for detecting small airway obstruction. So basically, the resistance is the highest in the middle. Okay? So if you look in here, the resistance will kind of like load up until it reaches its maximum, which is like in the middle of the like airways, and then it's going to decrease rapidly. So the main idea, guys, you just have to know like where is the highest resistance, which, as we said, in here, the medium-sized bronchi. And you know that basically measuring the resistance is not like a very good diagnostic test if you want to check for basically small airway obstruction. So basically, if we have cancers in the small like airways, or if we have any obstruction there, measuring the resistance would really not help us, because anyways, the resistance there is kind of non-existent. Okay, so that's like the main concept out of this. Do you guys want me to? Is this considered? Yeah, exactly. Silent lung disease is basically any disease that is in the like the terminal bronchioli, or basically in the, like, you see those generations, because again, we can't measure it. Like usually we measure the resistance, but in here, since the resistance is not there, we can't really know if like basically a tumor is there, or basically an obstruction is there. Is it clear?
Someone answered, okay, yeah. Someone answered trachea, but that would be again in the beginning, right? So it's not the highest resistance.
Okay. Let's
Next
move
question.
on.
No, it's like, I think the next few ones are like calculation, so you can take your time. So a man with normal lungs and an arterial PCO2 of 40 millimeter mercury takes an overdose of barbiturate that halves his alveolar ventilation, but does not change his CO2 output. If his respiratory exchange ratio is 0.8, what is arterial PO2, which is PaO2 approximately? You can take your time in this one because it's calculation. But someone answered already. It's fine. Oh, I forgot to put this class. Which I had one, this one. Oops. Yes.
Oh,
Wait.
yeah.
Okay.
This is the answer, but this is, I think, the formula.
Okay. Yeah.
Okay. You guys are doing well.
Yeah.
Okay. One more minute and we're gonna reveal the answer.
I don't get this one.
She means this over this is going to give
Okay,
this.
yeah.
Okay, guys, you're all right.
Yeah,
it is B.
It is B. Now, there I put the form. Yeah, it's fine. I put the formula in the next slide. Now, from this lecture, there was like two main formulas that are more important, like that are more important than the rest. One of them is this one. Now, okay, wait. So for this question, you don't need to use this formula, but I just put it here. Did he say that you guys need to know the normal values? Because okay, fine. Then it's fair. Because I remember I think last year they got a question on this, but they were only given barometric pressure, but just know the numbers in case he asks. So the way you would like the way you would calculate PiO2, which is the inspired oxygen, would be by the amount of oxygen in the inspired air times the pressure, like difference between barometric minus the water vapor pressure. Now this one is usually 47. Barometric at sea level is 747, and fractional oxygen in the air is 0.21 at sea level. So this would give 147, and you can have you can keep that as like the standard. If he doesn't give you, the inspired O2 at sea level is 147. That's why I'll put in the formula for this question, but wait, maybe I can type. I don't know if it's better. Oops, wait. Okay, you know what? So here. So PiO2. Oh, maybe this is like to take time.
Yeah,
I want to explain. Okay, PiO2 is 147. Oh, it will take so much time.
Wait, let me try.
Okay.
Yeah.
And 147. And in this one, you want to find arterial PaO2. Now, okay, wait, I can ask, can someone type in the formula? Like, what did you use to calculate arterial PO2 from the inspired O2? Because there's this formula, but I forgot. Like, I'll put it in later on. So PaO2, the arterial PO2 is equal to, I'll wait for someone to write it or say it.
My God, that Dr. Abdul Jabbar.
Yeah.
He always uses the pointer.
Is it the arterial PO2 is equal to the inspired oxygen minus the carbon dioxide over the ratio?
Yeah, that's it. Okay, so you guys,
Everyone
everyone, but it's like direct message, so I'll copy someone. Thank you. I'll just put this in for everyone to see. Oh my God, I know.
Yeah.
Okay, so PaO2, arterial O2 is equal to inspired O2 minus the arterial CO2 over R, and it's in the chat. Yeah. So now, as I said, you can use the standard for PiO2 as 147, and then you can subtract it from the values given here. So PaCO2 here, it's not like can I see? It's not given exactly, but they said that the ventilation was halved, which means that you're not breathing in as much, right? So the PCO2 would be higher. And by how much? They're directly proportional. So if, let's say, your ventilation or the rate you breathe in is lower, is lower. So PaCO2 in your blood, since you're not exhaling it out, it's double the amount. Because it's half here, it's double the amount. Now, so that would mean it's 40 times 2, which is 80. Now you put 80 over 0.8, which is the ratio. This is also the normal, like, standard ratio. Once you put that in and you subtract it from 147, you would get an approximate number of 50. Is that clear with everyone? I can do it.
It's just basic
Yeah,
math.
it's the formula.
Do you guys get it?
Do you guys get it? That's why.
Why do we double it again?
Okay, so wait, let me explain it. Okay, so the answer you would get is 47, which is approximately 50. Now, why do we double it again? So ventilation is the rate at which you breathe in, right? So let's say it's half, which means that you're breathing way less than you're supposed to. So the carbon dioxide in your blood would increase twice the amount. So if they say half, it's twice, because it's directly proportional again. Is that clear or no? Okay. This is the next question, right? Yeah.
Yep. More calculation for you guys.
Yeah. But okay, so what fraction of oxygen do climbers at the summit of Mount Everest, which has barometric pressure of 247, need to have a normal value of 150 millimeter mercury for inspired PO2? So the question is, which one? Okay. You said D, right? We'll wait for the other. Yeah, okay.
Yeah, I think I put myself unmuted. I'm sorry.
It's
It's okay.
It's fine.
Yeah, but like I think the normal O2 is I
Okay.
think D.
D. We'll wait for the others to reply. We got D. We got A. So we'll see. Can I see?
I'll take another one.
Oh,
Didn't like
okay. Okay, so we have D and we have A. Oh, wait, I'll give you guys time to calculate if you need to.
Yeah, don't worry, you have all
Yeah.
the time.
Also, we're almost done with the.
Don't worry, my phone is there. Guys, I'm taking a photo of her name. Okay. We're taking photos while you guys calculate.
Okay, wait. Yeah. So we got more answers. We got 8. Now, should I go ahead and ask?
Yeah, yeah.
Okay, so I get why people said D, why you guys said D. It's completely fine, like I understand. But the correct answer is 8. Now, like I said, the fraction of oxygen, the one you have to memorize is at sea level. So the fraction of oxygen in sea level would be 0.21, right? But in this case, they went like higher up the mountain, so it would change. That's what they're asking for. So you would use the same formula as like I sent
Yeah, the
up.
one we
The
sent.
PaO2 is equal to no, sorry, not this one. The one I explained here. Sorry. There's two
Oh, right,
formulas,
yeah.
sorry. This one. So you would use this.
Right. So
But
basically,
you put
since
in the
it's
formula,
yeah,
you put in the
it's-
values and you switch it. So wait, again. So PiO2, as they said in the question, was 150. Okay, so this
no, but I think yeah.
here, yeah,
So it's so we put 150 in
yeah,
here,
here
all right? And
is
then
equal to.
we wanna
You want to find this.
yeah, we wanna
yeah.
find this. They told us that the PB is equal to 247. So we're gonna do 247 minus the pH2, which is
Yeah.
47. Where did they get 47?
This is fixed, like for
okay.
water vapor.
So for pH
minus
20, wait, for pH2, okay, it's 47. And then we have
Yeah.
247 here. So it's gonna be 200, all
Yeah.
right? 200 times for
Times,
FiO2 equals
yeah.
150. So we're gonna do 150 divided by 200,
Yeah, which is
0.75, which is the right answer.
Did you guys get?
Yeah, did we
Yeah.
guys lose you?
It's just applying the formula, but you want to find the fraction. And when they say it's not sea level, it will, it won't be 0.21. Okay. I hope that was clear.
Shall we move on, or do you have any questions?
I think that's
I got it, but I remember Dr. Shams mentioning that the fraction doesn't change. What
okay,
fraction?
yeah. The fraction of oxygen in the air.
FiO2. But
Yeah.
this, I think he means that like FiO2 would not change at sea level, but if we go up at a higher altitude, it will definitely change.
Like
It's
the
not gonna
amount of
be-
oxygen you have in the air is like, it would be different.
It'll be less
That's why.
than it is down.
I just wanted to make sure, but. Oh, like this, you mean? But I mean, if they give you formulas, it can change if someone is breathing in artificial air. Yeah,
I don't know about that.
yeah, like you can have 100% oxygen and you can.
Oh, yeah.
But I know it says when you go up, like the number of like higher up, it won't, like the fraction of oxygen is 0.21. But in this case, like since they give you like all these values are given, it means you have to calculate, or like something. It's how do climbers that maybe they're breathing in higher like oxygen in the mountains. Like the ones. Do you guys get me, or did I lose you? But if, for example, if you get a question on using fractional oxygen, there's no other way to calculate it. Like this is the only formula. So you would, if they don't give you anything else, just use 0.21. That's not normal.
I think the question
Yeah.
is meant to be hypothetical.
Yeah, probably.
Yeah. It's just a test. It's
Yeah.
literally just a test if you know the formula and how would you
Like,
apply it. Literally, that's it.
Like they
It's
will
just
never
math.
have normal PiO2. You mean in this question? Yeah. All these numbers, yeah.
It's all I
They're
think,
not, they're not actual numbers. Okay.
Okay. So shall
Do you
we
guys
move
have
on?
more questions or?
I'll take the silence as a
Yeah.
yes.
No question. Okay,
No,
fine.
thank you. Come on. So regional differences in ventilation and perfusion of the normal upright lung affect gas tensions in the pulmonary blood. Which of the following best describes the gas tensions PO2, PCO2 in the alveolar capillaries at the apex or base of the lung in a healthy individual standing upright? I think we're gonna kill ourselves for this. Yeah, we're gonna fight the podcast.
But even I was confused in this one.
Yeah. Okay, we got a B. I think A. Yeah. B. Hamas. Okay, so the right answer is I want to
Okay.
see what will they say. What?
Oh.
I know. So basically,
I thought,
we thought
When
the
I was
question is
solving,
wrong.
I thought it was B too. That's why I understand. Like
The thing is, they're asking for alveolar capillaries, all right? So the apex, okay, I know that we have like increased ventilation in the apex, but the apex contributes to the basically anatomical, the alveolar dead space. So basically it doesn't give any oxygen to the capillaries, or it doesn't have like enough capillaries. So basically the alveolar capillaries that are at the apex, they're not gonna have a lot of PO2. We're gonna have a low amount of oxygen, all right? And then at the base, we have a lot of perfusion, but we don't have a lot of ventilation. So basically the capillaries there, they're going to have lower PO2 compared to any other capillaries in the lung. Doesn't make sense? Because at the base of the lung, we have like a lot of physiological shunting, the gas tensions are affected, we're gonna have like mixed venous blood and so on. So basically the oxygen level is not going to be as high as, like, let's say in the middle of the lung. Do you guys get this, or is it like confusing? I'm confused. Okay. So guys, listen, we have the lung, okay? Yeah, sure. So basically, the main idea in this question is that we're looking at the alveolar capillaries. We're not looking at the alveoli themselves, okay? So basically, in the apex, I know that it's basically like it has a lot of oxygen usually in it, but it is part of the alveolar dead space. Therefore, we have low perfusion. So the capillaries there, they're not going to take a lot of oxygen. Therefore, we're going to have low PO2, okay? Because it's part of the alveolar dead space. In contrast, the base is at the lower end, and then there we have basically decreased ventilation, but increased perfusion. Okay, so since we have like a lot of blood, but we don't have enough oxygen, it's going to be lower, like we're going to have lower PO2 compared to any other alveolar capillaries. And in the base, we usually have the anatomical shunts and all the physiological shunts that you guys took. Therefore, basically, we're going to have a lot of mixed blood there. So the PO2 is going to be lower than any, like compared to any other like like alveolar capillary. Do you get me? Wait, but isn't the ratio over the apex? So PO2 is high, or is it something else?
The ratio of ventilation to perfusion. Yeah, you're right. Like this one. This one.
Sorry. What exactly would be the question asked for the answer to be B? Like instead of alveolar capillaries?
It would be
the alveoli itself, because in the apex we know that we have a lot of PO2 in the alveoli because we have a lot of like O2, and in the base it's going to be, because we have lower ventilation, it's going to be lower PO2. You get me? Like the whole idea is, like the trick in this question is alveolar capillaries. Like if the doctor, or like if Dr. Shams asked, how would we describe the gas tensions in the alveoli itself, then we will definitely choose B. But because we're checking the capillary, we're going to choose C, because again, as I told you, in the apex, it's part of the alveolar dead space. So basically the perfusion is very low. So even if it has a lot of oxygen inside the alveoli, the capillaries technically get zero oxygen, or not zero, but like very low amounts of oxygen. That's why it's going to have the lowest PO2 compared to any part of the lung. And the base, as we said, because of the physiological shunts, because of the poor ventilation there, in contrast to basically the high perfusion, it's going to have lower PO2 compared to any other part of the lungs. Tamam? Like, do you understand the reasoning behind it? Where is the highest? In the middle of the lung, I think.
I think so, yeah.
Yeah.
If you're talking about capillaries, yeah.
It's probably where there is no, where the
balance.
VQ mismatch, like where we don't have VQ mismatch, you get me? Where the ventilation is equal to the perfusion.
Yeah. Okay, clear. So yeah, the ventilation to perfusion ratio, someone asked before. That's the difference between apex and base. But here they're talking about alveolar capillaries.
Yeah. Tamam? I'll move on.
I hope that's clear, yeah.
Is it clear?
I think
I'm scared it's not.
if you guys have any questions, ask.
Again, I'll take the silence as I am. So, Amanda,
actually,
okay.
yeah, I have in my notes like a diagram of the lung, and it says that the highest part of the lung has a PO2 of 132, while the lowest has a PO2 of 90. So I'm still kind of confused why the apex would have lowest PO2.
Because we're not talking about the alveoli in the apex, we're talking about the capillary. Like we want to know the PaO2 in the capillary. Like you're right, the oxygen is at maximal capacity in the apex if we're talking about like the presence of oxygen inside the alveoli. But if we want to know how much oxygen is in the capillaries that supply the apex, then it's going to be like at very low, because again, we said that the apex is part of the alveolar dead space. You get me?
Yeah, but this question threw me off.
Yeah,
I get you.
fine.
Yeah, it's just because of the alveolar capillaries. I hope like the doctor doesn't get you something tricky like that.
Yeah.
But if he does, like read thoroughly and make sure that it's like either like make sure, is it the alveoli itself, or does he want the capillaries that supply the alveoli? You get me?
Yeah, I think that's good. Thank you.
Feels like an English literature question. I swear a lot of the questions, because you don't like focus on a very tiny detail, you get it wrong sometimes. Anyways, moving on. A man fell asleep in his running car. He was unconscious when he was brought into the emergency department. With carbon monoxide poisoning, you would expect that his alveolar O2 partial pressure would be, while his arterial O2 content would be. So what do you think, guys? I have a C. A.
What's the difference between C and D?
Oh yeah.
Oh, never mind.
Oh, honestly.
It's a mistake, yeah. So even if they have the highest PO2,
So, yeah.
they're a part of the dead space, so less gas exchange in the capillaries, so less PO2 in capillaries. Yeah, Leon, that's pretty much it. A, C. Okay, so we have A and we have C. Shouldn't it be increased, decreased?
We'll see. Yeah. Wait. You mean D? The
Like yeah, the D,
option. Yeah.
maybe it was
Maybe.
increased, decreased. I don't know. But يعني, we can clearly see that D is not the answer. Okay.
Okay.
So the right the answer is, why do I always say the right question? Increase, decrease sounds right.
Wait, let's see.
Okay. So the right question, the right answer is normal and decreased. Why?
Okay.
Because guys, listen, we're saying that he has carbon monoxide poisoning, right? So usually in carbon monoxide poisoning, what happens is that the lung, okay, the lung, like the taking in of oxygen by the lung would not be affected because basically it's you're inhaling carbon monoxide and oxygen. What would usually be impaired is what binds to the hemoglobin in the blood. So the alveolar O2 partial pressure is not going to be affected. It's going to be normal because you're breathing in air that has the normal oxygen plus carbon monoxide. So you're breathing in like oxygen plus carbon monoxide. So the PaO2 is not going to be affected. You're going to have the same oxygen that you usually have inside your lungs. But the problem is that once carbon monoxide goes into your lungs, once carbon monoxide goes into the lung, it will bind to the hemoglobin. Yeah. Therefore, we're going to have less, the CaO2 is going to be decreased because the blood is not taking in so more dissolved oxygen, increasing PO2. No, the oxygen is not going to dissolve. Because usually oxygen will bind, like usually how oxygen is, it's like a large percent of oxygen is going to bind to the hemoglobin. A very tiny percentage of the oxygen is going to dissolve. You get me? Inside the blood. So the PaO2 is not going to be affected. While the CaO2, on the other hand, like the amount of oxygen that we have in the capillary is going to be decreased because the carbon monoxide took over and it basically
bound to hemoglobin.
Even if the binding, because it's kind of like.
Can I ask you one last question?
Yeah, sure.
The partial pressure of oxygen in the arterioles, it won't be affected either, because like the one that like the partial pressure is it gets affected by the free oxygen molecules that like they come from the alveolar PO2. And since we have normal PO2 normal, we're gonna have arterial PO2 normal. It's just the saturation that will be binded to the hemoglobin will decrease.
Yeah. So like the main idea is that alveolar O2 partial pressure wouldn't change because it doesn't affect your breathing again, like she said. But arterial, like in the blood, since carbon monoxide takes up much of the space in hemoglobin, there's less chance for oxygen to go into the blood. So there's less oxygen content in the blood.
Exactly, and the partial pressure of the oxygen is not going to change because I don't know. It's not affected usually.
Even if the binding sites are occupied by CO.
Wouldn't we have more oxygen in the lung?
So more dissolved O2 increasing PO2, even if the binding sites are occupied by carbon monoxide. I don't know, but like the total amount of oxygen content in blood, most of it is bound to hemoglobin. So like if most of the sites are occupied by carbon monoxide, like we are losing
maybe oxygen gets dissolved in the blood.
It does.
I'm not sure.
That's what I was thinking. Okay.
But the main idea in here, guys, to know that basically usually the lung is not going to be affected by the carbon monoxide. What will be affected is the content of oxygen inside the what is it called, the blood. So because the carbon monoxide is going to bind to the hemoglobin, the oxygen will not be able to bind to the hemoglobin, and the amount of oxygen that is there in the capillaries will decrease. So for the idea of the partial pressure, I think let's after the session, Momo and I are going to search over it, and we're gonna tell you a definite answer. Tamam?
But can you guys get
we can send it on the group. Yeah. But for now, did you get the general idea? When we say arterial O2, do we mean dissolved O2 or hemoglobin O2 or both? Arterial O2, we mainly mean the one that is with hemoglobin. You get me? Like the one that binds to the RBCs, therefore binds to the hemoglobin. Okay. So for the PaO2, we're going to like further look into it, and we'll tell you guys.
I'm just confused because wait, this says arterial. I just noticed it. Arterial oxygen contact, and then here it says.
Yeah, the arterial oxygen is going to be decreased
okay,
because carbon monoxide. Yeah. Okay, so basically, since carbon monoxide was mentioned, I thought that it's important, guys, to talk about the diffusion limitation and the perfusion limitation. So basically, usually if someone inhales carbon monoxide, it's not gonna be like perfusion limited, rather diffusion limited. Why? Because we know that carbon monoxide binds to the hemoglobin rapidly, all right? So it's not gonna depend on the blood flow because it will bind to the hemoglobin and directly move on. But like oxygen, you know how it's perfusion limited because we have a lot of oxygen in our lungs, and the like how much oxygen we have in the lungs does not really affect the PaO2, but rather how much, sorry, not the PaO2, the like arterial O2, because it depends on the blood flow. Is it rapidly flowing or is it slowly flowing? You get me? Because once the oxygen is saturated and it's bound to the hemoglobin, then we can't have more oxygen into the blood. But مثلا for carbon monoxide, we can usually it is limited by the diffusion, like how much carbon monoxide we have in the lung, because when it will bind rapidly to the hemoglobin. You get me? Do you get this, or is it confusing?
Wait, I just wanted to clear one thing. So arterial PO2 is a measure of dissolved O2. Sorry. Could you repeat? But I just wanted to say PaO2 is a measure of the dissolved oxygen you have in the blood, because that's what you're measuring, right? But yeah, that's it. Because someone asked, I remember. But usually, like the main like oxygen can be bound to hemoglobin to be transported or dissolved. Only produced. Yeah. That's what I mean. So someone asked, but partial pressure of oxygen is only produced by dissolved molecules, right? Yes, dissolved. Sorry about. But yeah, but you get that it can also bind to hemoglobin, like the carbon, which the carbon dioxide monoxide is bound to. Like it takes up that space. Okay, wait, repeat this.
Okay. So guys, you know how basically when we were talking about the uptake of gases, how they're either, like we have limitations. The limitation can either be because of the diffusion of the gas or because of the perfusion of the blood, all right? So oxygen and nitric oxide, they're perfusion limited. What do we mean? Like basically, if you see, if we have like the partial pressure inside the lung, it's going to increase until basically the partial pressure of the, like, let's say the gas is equal to the partial pressure inside the lung, inside the capillary. So basically, if the blood does not move, then basically the nitric oxide is not going to be absorbed more. You get me? Because basically it reached an equal level, like see here, Pa equals Pc. So the partial pressure of nitric oxide inside the alveoli is equal to the partial pressure of this gas inside the capillary. So once this state is reached, then there will be no more like gas exchange, all right? And this is due to perfusion limitation, because the capillary will have blood until the blood moves and we have new blood. The exchange between the alveoli and the capillary will not happen. You get me? Is this clear? Okay. But carbon monoxide, on the other hand, okay, it's very different. Why? Because basically carbon monoxide, usually it's, wait, so basically we have a lot of carbon monoxide inside the alveoli. And once it binds to the hemoglobin inside of the blood, all right, it's not gonna, what is it called? There will happen no more diffusion will happen. So the partial pressure inside the artery is going to decrease, but the partial pressure inside the capillary won't increase. All right. So because the partial pressure inside the artery, sorry, not the artery, inside the alveoli is going to increase, and it's going to always be more than the partial pressure inside the capillary, then carbon monoxide is limited by diffusion. You know, like the idea is that not all of the carbon monoxide inside the alveoli can go into the capillaries. Therefore, because we always will have more carbon dioxide, the partial pressure of the carbon dioxide in the alveoli will be more than the partial pressure in the capillary. Therefore, the limitation is not perfusion anymore, it's diffusion. All right? Makes sense. Yeah, exactly. So it depends. For nitric oxide, transfer stops because the blood will become saturated with nitric and no pressure gradient. That is why to have that pressure gradient that will drive high movement. Is this right? Yeah. So basically, yeah, like it's saturated. It's not gonna move anymore. But in here, even if it's saturated, we still have partial pressure that is more in the alveoli. Like as you can see here, PA is more than PC when blood leaves the capillary because it can't be saturated at a higher level. Therefore, it's going to be limited by the amount of carbon monoxide that is diffused through it. You get me? So in here, like nitric oxide and oxygen, they depend on the amount of blood we have, the amount of new blood we have. But in here, it will depend on how much carbon monoxide will diffuse into the blood, and it will never be like high, like they will never, PA is never going to equal PC with carbon monoxide. So that's why it will always be diffusion limited. You get me?
You guys get it? Okay, yes,
Because CM depends on free spots in the
yeah.
yeah. Can I move on, or do you have any more questions about this? All
Okay.
clear.
I hope that was clear.
Clear.
Oh, no.
Okay.
I can read the next one.
Yeah.
Okay. So a 12-year-old boy has severe asthmatic attack with wheezing. He experiences rapid breathing and becomes cyanotic. His arterial PO2 is 60 millimeter mercury and his PCO2 is 30 millimeter mercury. Which of the following statement about this patient is most likely to be true? We'll wait until you guys. Yeah, we're okay.
The two next two.
Yeah, okay.
Yeah, we got a couple of Ds.
Okay. I feel like we repeated this too, like before. That's why.
Okay, so
Okay.
the right
correct
answer
is-
is yeah, we got a B and an
We
A
got a
too.
B2. Okay.
So the right answer is D. Can someone who chose D explain why? Because we're
Did you
gonna
do it by?
explain.
Yeah, I think it's just like his hyperventilating. Yeah.
He's hyperventilating, so he's expiring more CO2.
Yeah.
Yeah, that is true. Plus, I feel like this is easy.
Yeah.
Rapid breathing. So
Yeah. Also, I think it's like better to know. Is it? I don't know if we like if we knew the values. Yeah. But 30 is generally
Honestly-
low for PCO.
honestly, guys, memorize them.
Yeah, so it helps you.
Ventilation perfusion ratio is increased
Why
in the
B is wrong?
affected areas of his lung.
Okay. Wait.
Can I ask a question? Why is A wrong?
Okay, we can go through all of them if you want.
Okay.
So
FEV/FVC
Is
is
increased.
increased. Usually it is increased, and what is it called? restrictive, right?
Restrictive.
Yeah,
So
so,
not
restrictive disease. But basically, he's having an asthma attack.
which is COPD, isn't it? Which is the other one, obstructive. So it's
Yeah, asthma
decreased.
is part of COPD, and we have wheezing. So that's why it
Yeah.
is not going to be FEV
Asthma is
over
obstructive.
FVC. So basically, A is out of the way
Yeah.
because basically it's obstructive, not constrictive. Okay.
Okay. So asthma is obstructive, not constrictive.
Yeah.
Yeah, it's obstructive.
But like, it's kind of confusing because we're first thing first, like in the asthma attacks, we're constricting the alveoli, and when we have like constricted alveoli, basically the emphysema, like the compliance kind of decrease. I don't know.
If you
Or
think
am I?
if you think of it as emphysema being difficulty to exhale, that's the same thing you have with asthma. You can inhale, but you have a problem with exhaling, so that's obstructive.
That's
That's how it is.
they fall under the same like category. It's like emphysema, but not really. It's just a constriction of bronchiole. So you would consider that as okay. Wait, why is B wrong? Someone was saying.
Ventilation perfusion ratio is
Is
increased
increased.
in the affected
Okay.
areas of his lungs. So basically,
That
guys,
means that-
ventilation is decreased.
Yeah, like
No, it is increased.
No.
We have hyperventilation. So ventilation is increased, but perfusion,
I don't think it's increased. Like the
yeah, because
ratio
perfusion is
not-
going to be normal. It's just that the ventilation is going to be affected. And we cannot actually, like, for asthma, we
Oh,
cannot
yeah.
think of VQ mismatch, you know?
VQ mismatch happens more with like if the question was about hypoxia or something about there's
Loss of air,
yeah,
like suddenly obstruction
Yeah.
in the lung.
or blood supply.
Or blood supply,
That's
yeah.
what you think about VQ, but in asthma, not really. I don't think, right?
Yeah.
Because I hope that made sense. But D is like D is the most correct answer. I'm trying to read the other.
And also in the explanation in here, they say that basically the FEV and FVC ratio is decreased. Therefore, we have poor ventilation of the affected areas, decreasing the ventilation perfusion ratio and causing hypoxemia. But in here, it says that the ventilation sub-perfusion ratio is increased.
Yeah.
But basically, because the FEV to FVC in this patient is decreased, because basically we said it's obstructive, then the ventilation perfusion is going to be decreased, not increased.
So like hyperventilation is different from ventilation to perfusion ratio. And then someone said, in asthma, I'm assuming
They both increase, but
which doesn't change the ratio. No,
No, it does not. That listen,
poor
it's,
ventilation, so it decreases the ratio.
yeah, exactly. We're gonna have poor ventilation.
That's right.
Therefore, the ratio is going to decrease. So B is not even correct. You get me? Because if we have an obstructive disease, the ventilation perfusion ratio is gonna decrease, not increase. All right.
And E is the opposite. So residual volume again would be increased in obstructive, like all the volumes. Does that make sense with everyone? Like why it's not A, why it's not B? You can eliminate them once, like
Yeah, like once you
Yeah.
see them, because like, okay, we know it's
Okay.
obstructive, we remove
Yeah.
A. And because it's obstructive, they say that the ratio is increased, but in fact it's
Okay.
decreased. And the PCO2 is higher than normal because of inability, what?
inability.
Inadequate gas exchange, that's not true. His PCO2 is lower than normal, right?
Yeah.
His residual volume is decreased, that's not true because it's an obstructive disease. All right.
I hope that was clear.
Oh my God, why did the answer come out?
Okay.
No. Okay, good. Okay, now you know the answer. Explain why.
They didn't see it.
Okay, good.
I guess.
So which diagram in the below figure best illustrates the pulmonary vasculature when the cardiac output has increased to maximum extent? Like, let's say the person is exercising. Which one would it be? Cardiac output. Cardiac output causes distension and recruitment, so A. Yeah, that's correct.
Everyone's saying A.
That's an easy question.
Okay.
Very
why?
nice.
Let's see.
Okay. It is true.
Yeah, it is true
Because we
of
have
recruitment.
recruitment and distension.
Yeah.
Halas. And this one, guys, is kind of similar. During exercise, pulmonary vascular resistance is reduced. Which of the following pulmonary changes most likely contributes to this decrease in PVR? So the pulmonary vascular resistance is decreased because we're exercising. What do you think causes this? D.
Okay, yeah, I think it.
Yeah.
But
It's
if you
literally-
guys know the concept, yeah.
Yeah, it's literally like the previous one because
Yeah.
increased cardiac output would cause increased distension and recruitment. So the
Mhm.
recruitment of closed capillaries would cause decrease in resistance because we're having more like we're
Yeah.
increasing the surface area.
And the pressure, like pulmonary pressure, would increase because you're having more blood flow and more perfusion.
Yeah, the
So
capillary, like the
exercise.
total capillary area of the lung is increasing. So basically, the pulmonary vascular resistance is going to decrease.
Oh, last question.
So the last question.
It's more of like memorization, but healthy people can increase their ventilation either voluntarily or in response to stimuli like hypoxia, hypercapnia, exercise, hyperthermia, and acidic pH. Which of the following mechanisms is capable of producing the greatest minute ventilation? Okay, I'll wait forever. But this is like
C.
Okay.
Why do you think it's C?
Okay, fine. Why do you think it's C? But
By the way, I googled the
Google's
question of the
question-
VQ mismatch. Diseases like emphysema have a high ratio, and diseases like asthma have a low ratio. Ah,
diseases like emphysema have high ratio, and diseases like asthma. Okay.
mhm. Listen, as long as it's not in
Mm.
your lectures, don't
Yeah, it's
worry
fine.
about it. Yeah.
But asthma, if you want to think about it, maybe the ratio changes because of perfusion. So you can't separate between. Okay, that's fine.
So you can't separate between obstructive.
Yeah,
Yeah.
I was thinking of asthma only because you have low ventilation, and yeah. But okay, so
Yeah. So back to this. Why did you?
I
guys
hope that's
choose
clear
C?
to everyone. Like the one that. Okay, everyone chose C, but why? But it's. Okay, I'll just ask. See, because it
it's in the
wasn't.
slides.
Okay, yeah, that's true.
It's in the
It's not-
lecture.
I just got this because I remember.
Why not
I
A?
think we got it too.
Why not
Okay. So all of this, all of this will lead to an increase in ventilation. And for whoever who doesn't know, like greatest minute ventilation just means like the frequent, like, so ventilation rate is made up of ventilation, the amount, okay, times the frequency, like how fast you breathe in. And that just means greatest minute ventilation. It's like the rate. But overall, just know that voluntary effect is the greatest like effector of this rate, not anything else. I know all of this they can cause, but not as strongly as when you voluntarily do it. And also, yeah, that's what Dr. Shah said. So just know that.
He gave us all of these reasons in order. What was the one right before voluntary? So
Right
the
before?
highest before voluntary? I can't remember.
No, I think exercise.
Honestly, I'll check. Which
Oh,
lecture
it's
was
here,
that?
this one. But I remember it was voluntary. Wait, let me see.
Yeah, you're right.
Yeah.
The
Which
one
lecture was it? Do you remember? The 8th, like the last one? Or...
I think it was the
Saying
last.
exercise.
Not
Basically,
sure.
exercise.
Okay, last one. Because
Yeah, it was the last
yeah,
last
yeah,
slide.
it is.
A bar graph.
It is, yeah. It's voluntary, then exercise, then PCO2, pH, PO2, and then yeah. It's the last, like the last picture.
Yeah.
But just know, yeah, voluntary control is the like the most, it affects it the most. That's it. Voluntary means like someone asked, right? What does that mean? It just means like you're doing it, like you're trying
choosing to
breathe
do
in,
it.
yeah, you're choosing to breathe in faster. Also, you
Like
do it
it's not
yourself,
caused by exercise or something else. You're choosing to hyperventilate
Yeah.
or hypoventilate.
yeah.
Increase their hyperventilate. So you're forcing it yourself.
I think. Wait,
Is
I
it
had one
clear?
question. Is everything clear?
Why did it move the iPhone?
Okay, everything's clear. I hope this really helped. I don't know. I hope we were able to like cover all the important parts of pulmonary physiology.
I feel like you guys have to really concentrate
Yeah,
on, let me tell you what. I don't think you have this
wording
open.
first, because
Yeah, the
alveolar
wording,
capillary, that
yeah.
it can get confusing.
And for the perfusion,
Yeah.
we didn't put a lot of questions on them, but how we have basically an area with high ventilation and an area of low ventilation, and then we have the hypoxic and hypercapnic, like how like one part of the alveoli is hypoxic and hypercapnic and the other is hyperoxic and hypocapnic, and what are the responses. I feel like this is very important. It's in lecture 5.
Yeah.
The reflexes to match ventilation and perfusion. You guys have to thoroughly go over that, because I think like the doctor will express a lot of questions in it.
Okay.
And I think that's it. If you guys have any
That's all.
questions, we have
But you guys did great today.
Yeah,
I
wallah,
was
you
like,
did
yeah.
really well.
Oh yeah. You can let us know if you have any questions afterwards too.
Yeah.
If you don't mind.
You can send us a message on WhatsApp, which I actually prefer. Don't send me an email.
Yeah.
Thank you guys. You're so cute. Aww. And we
Thank you
wish you
guys
the
for-
best of
yeah.
luck, guys, in your exam. Inshallah, you're gonna all ace
Inshallah,
it.
it will be good.
And it's just CVP. It's gonna pass.
Do I?
Yeah, stop the
sure.
recording. Yeah.
Thank you so much, guys. Thank you.
I have a question. It's
yeah,
not
sure.
related to any of the questions we